Well, hello everybody. At least everybody who came. Take a quick roll while we are in limbo. Glad to see Cole Salazar is here as he is presenting today. No, he's not. No, you presented already, didn't you? McEnany. Eric McEnany. Holy McElhaney. Simmons and Gordo. Gordo is here. Hello. Bailey Lyons. Okay, did I miss anybody? Okay, I think I got everyone's attendance at this point. How many people we got here today? 15, 14 students. I think there may be one person who's not here yet, but as we don't have a whole lot of time, why don't we go ahead and get started? I'm going to find out who signed up first. Cindy Barrier. No, I'm sorry. What's today? Oh, today's 8th. Okay. Yep, Sydney Barrier. Are you ready?
It's me. Yep.
All right, I'm going to hand over control to you. Okay, so you can go ahead and share your screen and rock and roll.
Okay, so I did my research on one of the surface proteins on the influenza virus. It's called hemagglutinin. So a little bit about the influenza virus. So there's 4 types. There's A, B, C, and D. Influenza A and B, they're most responsible for human illnesses and the flu virus. Influenza A is further divided into subtypes, and this is because of the changes in the surface proteins. And the 2 surface proteins are hemagglutinin and neuraminidase. So the influenza structure, it's a helical in shape. On the picture on the right, there's the protein spikes. The most frequently one on the surface protein is hemagglutinin, and that's what my research is on. And then there's the blue ones, that's neuraminidase. So the virus is an envelope structure, or an envelope virus. It contains single-stranded RNA. The capsid is responsible for the virus's shape and recognition and entry. So this is the structure of the protein, hemagglutinin. As you can see, there's in the picture labeled A, this is a single monomer, and so 3 of these make up the protein structure. Then there's 2 polypeptide chains or subunits that make up the structure. There's hemagglutinin 1 and hemagglutinin 2. So HA1 consists of the globular head, which is contains all the receptor binding sites that assist in attachment to the host cell. And then HA2, it's the consists of the stem and or the stalk domain region, and it consists of the fusion peptide. The fusion peptide is especially important in membrane fusion, so so the genetic material can get transferred into the cytoplasm. The disulfide bond is important in holding the two subunits, HA1 and HA2, together, because usually the protein undergoes conformational changes, and so the two subunits are held together by this bond. And then this protein structure is very flexible. In this picture, you can see the globular head is a lot flexibility because it has all these receptor sites, so it can assist in attachment. And this also assists in the pathogenicity of the virus. So what does this glycoprotein do? It assists with the recognition and attachment of the virus to the host cell because it contains receptors on the globular head. The host cell contains sialic acid receptors, which this is what the glycoprotein binds to. And so once inside the cell, the cell gets engulfed by endosymbiosis and then, endocytosis, and then the transferring the genetic material into the cell. And then, so this contributes to the virus's resistance because, so the protein contributes to the resistance of the influenza virus because it undergoes these amino acid changes on the glycoprotein, the head. So over time, this leads to the stability and the pathogenicity of the virus. So this protein is very stable in acidic environments. The acidic environments actually activate the protein. So once activated, the protein undergoes conformational changes, and which leads to the emergence of the fusion peptide. So the fusion peptide, basically, it combines the virus's membrane to the endosomal membrane, which then the protein can transfer the genetic material into the cytoplasm. So there's different levels of pathogenicity, and this relates to how pathogenic the virus is and the ability of it to spread to different species. So the typical range of pHs are 4.8 to 6.2. High pathogenic viruses have a wide range, so they're better able to spread to different species, and so the moderate pathogenicity has a narrower range. That makes them avirulent, so that means they can only stay in one type of species. An example of this is the H5N1 strain. This spread from birds to humans, so it's very highly pathogenic. And then the levels of pathogenicity can result from mutations, making them adaptable to varying pHs. There was an amino acid change substitution in the stalk domain of the H5N1 strain, and that's why I was able to spread from one species to another. So there's antibody escape mechanisms, and this is why the virus is able to, it changes subtypes, and then that's why we need vaccines each year because of these escape mechanisms. So the protein undergoes 10,000. So 10,000 single amino acid mutations. These usually happen in the globular head of the protein right here. So you can see all the different antigenic sites. these mutations, they're also called epitopes. They can also happen near the fusion peptide. There's like a couple down here. But basically, and then, so they decrease the binding of the antibodies and they increase the binding to the host cell. Then there's these structures called N-linked glycoproteins. And as the virus replicates, more of these structures get added on to this protein. They can assist in blocking the antibody from binding because they block it sterically. They're also involved in more antibody escape mechanisms because they're shown to increase the fitness costs after antigenetic escapes. So antigenetic drift versus antigenetic shift. This happens usually in influenza A viruses. The antigenetic shift drift happens all the time. They're basically small mutations that change the surface protein binding sites. This is why we're constantly coming up with new vaccines each year. This occurs over time because the virus replicates continuously. These small mutations produce viruses that are closely related to each other, so sometimes our immune system can recognize and just attack these viruses, but over time, these changes can accumulate and result in viruses that are not so close to each other. Sometimes this is a reason why we're susceptible to the flu each year. And then antigenetic shift, this happens less frequently. It results in new surface proteins, the hemagglutinin and neuraminidase that infect humans, and they result in new subtypes. So this can happen when an influenza virus from an animal has the ability to infect a human. This has little to no immunity against, we have little to no immunity against these viruses, and then this is why they can cause like pandemics, and an example is the H1N1 virus. What do antibodies target? So in my research, there were narrow strain specific antibodies. They usually target, or vaccines usually target the globular head of the HA protein, which, because the protein consists of a bunch of receptor sites and epitopes. So, so hemagglutinin plays a crucial role in the virus's virulence ability. So most vaccines target this protein, especially epitope sites on the head. Because they're easily acceptable or accessible to antibodies. There's also strategies to target the epitopes on the stem of the protein, but the stem is actually more conserved and it's less exposed. So there's less mutational changes, but sometimes they're harder to get at. But there's broadly neutralizing antibodies that is a strategy that they're coming up with, and there's one antibody, the F16 V3 antibody. This targets the epitopes on the stem, and it inhibits the membrane fusion by stopping the conformational changes of the protein. And then there's also immune refocusing. So there's approaches that are being done to target also the stalk domain by blocking antigenic sites on the globular head to get more at the epitopes on the stem. Okay. Overall, the protein contributes to the virus's pathogenicity, and this is because of the very stable protein in the acidic environment. And it has the ability to undergo mutational changes to resist the antibody bindings. This protein helps in attachment and recognition and induction of the genetic material, and then changes with different subtypes of the HA protein can result in antigenetic shifts, which can lead to potential pandemics. And overall, this is a very stable and resistant glycoprotein. So yeah, that's it.
Okay, we're going to throw it out to the crowd for questions and comments. We've got one chat. When a flu vaccine is made before flu season, how do they determine which flu is going to be prevalent in society? Good question.
Good question. How do they determine what? What's the question?
How do they determine which strain to make the vaccine against?
I don't think I know the answer to that.
I think basically they see which strains are around and they try and make a best guess as to what is the one that's going to catch on.
I know some or a lot of vaccines have different subtypes in them too. Like there's like 2 subtypes for influenza A and then sometimes 1 or 2 for influenza B. And then I think the next year after that, like obviously because of the mutations, so that vaccine won't work for that specific type. So I don't know.
Right. Okay. Any other questions or comments? Questions about the flu? Well, we don't hear much about the flu now that we got this other virus going around.
Yeah, true.
Flu's out there. Get your virus. Get your vaccine. Okay, no other questions or comments? All right, well, I'm going to let Sydney off the hook at this point. Withdrawing your co-host permission. Thank you, Sydney. Very well done.
Thank you. I don't know how to do this.
That's okay. I took care of it, I think.
Okay.
I don't know. Maybe not. We still see your thing. Oh, well. I'll let the next person up, and then we'll be able to change at that point, I think. All right. Bailey Lyons is up next. I will make Bailey co-host. There she is. Okay, Bailey, you should be co-host now. Can you bring yourself up and see if you can share your screen?
Yeah, I can share it. Do you see it? Is it there?
Sorry, I'm saying yes while it's muted.
Oh, okay.
Good.
Okay, so today I'm talking about degenerative myelopathy. It wants to. Okay. So what is degenerative myelopathy? It's easier to say DM, so I'm going to say DM. So degenerative myelopathy or DM is a neuroprogressive disorder. It's a degenerative and it's in the spinal cord. It causes weakness and paralysis in the hind legs of dogs. Like in the picture here, you're going to see, you've probably seen videos of dogs in wheelchairs or dogs dragging their legs around. That very well could be due to DM. Breeds you're going to most likely see this in are German Shepherds, Pembroke Welsh Corgis, Boxers, and a few other purebred breeds. Sorry, it's not letting me. There we go. So what is the cause of DM? So in 2009, it was discovered by researchers looking at the similarities between ALS, which I'll talk about in a later slide, to DM. The main cause, it was discovered that it was the SOD1 gene and it plays a key role. And there is a insertion of a new nucleotide. So the SOD1 gene is superoxide dismutase 1 and it's found on chromosome 31 in dogs. And you're going to see a switch from a guanine replacing with a adenine, resulting in a nonsense codon. The SOD1 is an enzyme. It's found in all cells throughout the body. It attaches to copper and zinc molecules in order to break down superoxide radicals, which are negatively charged toxic oxygen molecules. Those radicals cause cell and tissue damage. This picture is just dogs' chromosomes, and 31 is in there so you can see. So in a case study that they did on Pembroke Welsh Corgis, they took 38 DM-affected Pembroke Welsh Corgis and 17 non-affected Pembroke Welsh Corgis. They were all over the age of 6. They looked into the region CFA31, which is basically just that chromosome 31 that I was talking about. And that's when they found that G to A mutation was really in this case study done. But what they also noticed was that there was a lot of myelin and axon loss in the white matter areas of the brainstem, as well as the neuronal cytoplasmic inclusions of the spinal cord. In figure 2A, you see all the white is really going to be that loss of the myelin and the axons, and then figure 2B is a normal spinal cord of a normal dog. The neuronal cytoplasmic inclusions normally help bind antibodies to anti-superoxide dismutase. So the processes of damage and how you see the symptoms starting to present starts with progressive upper motor neurons becoming spastic. And then you're going to see the general proprioceptive ataxia in the pelvic limb region start to degenerate. And that's when you really start seeing the loss of motor function, and then the symptoms start to portray themselves. There's 4 stages of DM development. I have a short little video that I can show you here where you can see the beginning stages of the DM development that I'll show in a second. The first stage is general proprioceptive ataxia with spastic UMN paraparesis. UMN is the upper motor neurons. There, it's usually damage to the T2, T3, like L3 vertebral areas of the spine. The next stage is non-ambulatory paraplegia. That's when the dog is strong enough to move their legs and wag their tail, but they're unable to walk or hold up their own weight very easily. The third stage is LMN paraplegia to thoracic limb paraparesis. LMN is the lower motor neurons. That's when you see the loss of function in the hind end region, and then the partial loss of thoracic limb function. This is what the paraparesis is. And then the last stage is the LMN tetraplegia and brainstem dysfunction. Tetraplegia is the inability to move the lower motor neuronal part of the body completely. And then the brainstem dysfunction is when you're going to see the dog losing control in certain areas of their body where they can't really control, for example, the urination and their defecation and things like that. So I'll show you this video. Just fast forward to here. You're going to see the dog come in soon, and he's going to be, as you can see, he's kind of struggling to hold up his back weight a little bit. He's stumbling when he walks. This is a German Shepherd, like I said before, so they're really prone to developing DM. But that was just a good video to show you kind of what that beginning stage looks like. Get out of here. Okay. And so the symptoms of DM. The symptoms usually present around 8 or 9 years of age, but you can see it a little bit before and you can see a little bit after. That's kind of just the average that symptoms start to present. You're going to see buckling within the knees in the beginning stages, like you saw with that German Shepherd I just showed. Difficulty standing. This causes decrease in rear motor function. That's really the main symptom that you're going to see in these dogs, is the decrease in the rear motor function. And inevitably, it leads to paralysis of the hind legs, which is, for example, this corgi right here in the picture. You're going to see that the back of the body, he's unable to hold up the entire back of his body because he lost all function in those hind legs. And they'll have the inability to control urination or defecation, like I mentioned before. So the paralysis starts to move from the hind legs forwards, and eventually it's not just going to be the hind or the rear end that's paralyzed. It's slowly going to move all the way forwards to the front legs, and then eventually the dog is going to be completely paralyzed, and then it eventually leads to death. So diagnosis of DM is extremely, extremely crucial because it is such a deadly disease. Most people actually misdiagnose hip dysplasia in the beginning stages. Not most people, I should say, but a lot of veterinarians will. Especially because, like I said, they're present in German Shepherds, and German Shepherds are really well known for having issues with their hips and having hip dysplasia, or any large breed dog. Same goes for boxers, like I mentioned before too. But eventually, even if they are misdiagnosed, they're going to see that their dog is just getting progressively worse and worse, and that treatment for hip dysplasia isn't really working. And then that usually leads to diagnosis of DM. But if that doesn't happen, a veterinarian needs to rule out all other possible diagnoses before finalizing with DM. Again, that's because people usually go the route of euthanasia when a dog is diagnosed with DM and it starts to get too much to the point where the dog can't really stand very easily or very well. So to be sure, a vet usually can perform x-rays, CT scans, MRIs, or myelograms. They'll do x-rays to look at the noticeable changes in the vertebral bones, looking for fractures, disc movements, ruling out any of those possible explanations. In a CT scan, a vet will look more so at the stability of the spinal cord, make sure the spinal cord is stable enough in the vertebral areas. To rule out any possibilities of that. And then the MRI is similar to the CT scan, but looking more into the spinal cord and make sure there's nothing wrong with the internal of the spinal cord first. Myelograms aren't really used very often in veterinary practice, but it's very similar to a CT scan or an MRI. They just use different dyes to highlight different areas that they're looking for. And then here's another photo of the loss of the white matter in the spinal cord. This can prove a dog had DM, but obviously you can't use this to prove a dog has DM, if you know what I'm saying, because you can't splice open a spinal cord while the dog is alive. But after the dog passes, you're able to look at that, and you can see all that pink area is that degenerative white matter. And I have another short video. I don't think you can hear what
this is Dr. Andrew Jones. In this edition of Veterinary Secrets, I'm going to talk
so
about
I'm
my
just going
dog
to talk
Jesse's
over.
bad back.
If you can
In
hear, I'm
particular,
sorry if I'm
his
talking
condition,
over, but
degenerative myelopathy.
hold on, sorry. Somebody just called me.
We can hear it, Bailey.
Okay.
So this is my older dog, Jesse, here. Jesse is 16.
Okay.
Portuguese water dog cross.
So this is the vet's dog,
Healthy most of his
and
life.
he's going to look over and do a quick exam of what a normal vet would look at when examining a dog with possible DM when a patient comes talking about the symptoms.
I did notice that
And so,
down the stairs. So what's happened is
there
not
we go.
only is he weak walking around,
He said that he's weak walking around, and he's gonna check the dog's ankles, knees, and hips and check for any pain, which is what he's doing now.
I'm able to find out that he actually is fairly comfortable.
Saying that there's no pain in his dog. This dog that he has DM, which is what he's doing. And so he's saying how he's going through and that the dog seems fairly comfortable. He's not in any pain. He's not yelping. He's not flinching. Now he's feeling the spine and feeling the vertebrae to see if there's any, hip dysplasia signs, any pain.
So then when I do a more thorough exam,
and now he's talking about a more thorough exam. So what he's going to do is called knuckling, which is where he's going to flip the paw of the dog's paw over. And as you can see, the dog is not getting the signal to flip his foot back because of the degeneration in the spinal cord. It took him a while to get that foot back up. And that's just showing, like I said, the degeneration of the spinal cord. The dog's not receiving the signals that his back legs are in the proper position. So he's not understanding he needs to fix his leg. There's no reflex there.
This is Dr. Andrew Jones.
All right, so amyotrophic lateral sclerosis. This is the ALS that I was talking about before. So ALS is a neurodegenerative disorder that affects the upper and lower motor neuronal systems in the body, and this is in humans. This isn't in dogs. So this causes, very similar to DM, progressive weakness and muscle atrophy throughout the body, leading to paralysis and then death, which, like I mentioned, DM is very similar. The genetic mutation in ALS is also caused by the SOD1 gene. That's what's really coinciding with these two, and also spinal cord degeneration looks very similar as well. This goes over in ALS. You can see it's not as densely colored, I guess, from the dyes, and that's because due to the degeneration of the white matter and things like that. The difference here between the genetic mutation on the SOD1 gene is that in ALS, there's over 120 different mutations on that gene that cause ALS, while in DM, as far as we know, there's only one mutation, and it's that G to that A. So in a case study done, they looked at markers and receptor expression, and this in dogs with DM, and they look and found upregulated expression of BIP GRP78, which is an endoplasmic reticulum stress marker. They used immunocytochemistry within the spinal cord to show the stress marker expression in the microglia and the astrocytes. They also noticed an increase in level of apoptosis, signal regulating kinase 1 as well as Xbox proteins. The kinase 1 and the Xbox proteins play a key role in inflammation of the spinal cord, and activation of unfolded proteins is the cause of the inflammation in that spinal cord. So as for treatments, there's really not too much that you can do about DM. Like I said, it always leads to death, whether it's euthanasia or whether it's naturally because of the degenerative myelopathy. So most dog owners do go the euthanasia route because after a while, you don't want your dog to suffer anymore, even though, like the vet said in that previous video, they don't really feel pain because they have the degenerative issues with the spinal cord in the first place, but it's still not really a comfortable life to live when you are dragging yourself around or in a wheelchair. So some vets will occasionally recommend trying B12 supplements. This increases neuronal function or helps maintain neuronal function. It's not necessarily proven that it works, slow down the process, but it's theorized that it can help slow down the process. They'll also recommend adding more fatty acids to the dog's diet. Fatty acids just kind of help with the inflammation in the spinal cord, help reduce that. So in this case study, another case study that was exhibited was they looked into photobiomodulation therapy. So photobiomodulation therapy includes rehabilitation therapy and an at-home exercise plan. There were two different groups. There was group A in this study, and group B. They looked at dozens of dogs who qualified. It originally started with like 800 something dogs, but they all had to qualify and make sure 100% that it was degenerative myelopathy and nothing else causing this issue with the dog. So in group A, they had much more extensive at-home therapy and exercise plans rather than group B. They wanted to see how much at-home exercises would play a role in extending the dog's life. So the rehabilitation therapy used was mostly, like in this picture here, the treadmill and the water, which you probably see a lot of animals have used in videos. The water obviously helps support their weight so there's not so much weight on their legs, and it's helping kind of just move their legs around. It's basically just physical therapy for dogs. And photobiomodulation therapy itself is actually laser treatment. So in group A, they noticed that dogs who were treated in the photobiomodulation therapy compared to dogs who were not treated at all lived up to 12.53 months longer. And then dogs in group B who had a less extensive treatment plan and at-home exercise plan lived only up to 1.6 months longer than a dog who had no treatment at all. And like I said, that's really nothing you can do about degenerative myelopathy. It is a harsh disease, and it's not extremely common, but it is more common in certain breeds. And that's that.
Okay, let's throw it out to the crowd for some questions. I have a quick question. So you said corgis and German shepherds are commonly getting this. Do other dogs get it too, or is it mainly in those lines?
Yeah, other dogs can get it too. They don't know exactly why the certain breeds are more likely to get it. There's a chance that it could just be due to breeding, and they just kept breeding these dogs more and more with this gene mutation, and they didn't know. So, and then those dogs go on to breed, and it kind of just spread that way. But any dog, I guess, could get it. It's just a lot less likely if they're not one of those breeds. They're less likely to have the gene mutation in them.
Okay. Question from Tyler Montano. Has the development of the show line of German Shepherds with sloping backs increased the likelihood of hip dysplasia?
Not necessarily. Oh, hip dysplasia? A little bit, yeah. I would suggest or theorize, I should say, that dogs or German Shepherds years ago, prior to the German Shepherd that we know now, had higher hips actually, so they probably were less likely to have hip dysplasia. But now with the sloping of the hip in the past few probably like 20-30 years or so, it is getting lower and lower. That does play a key role in the hip dysplasia because they have so much weight pushing down on those back hips. And also they're very active dogs, usually trained for the military and the police, so they're putting a lot of pressure and work into their hips as well, which is just making it worse.
Good. Is there a way to screen puppies to see their chances of developing DM?
I don't know for sure. The only way you would know is that if they got a DNA sample from chromosome 31 on a dog and then tested it to see if they saw a genetic mutation there. But I don't know if the mutation appears instantly in the puppy and then it just does and it stays dormant, or if the mutation happens completely randomly in the middle of their life. I'm not 100% sure about that.
Okay, good answer. I like that from a molecular point of view. Well done. Okay, so check the time, 1:05. That's our 20 minutes. So why don't we move on at this point? Our next talk is Vanessa Gordon.
Hello.
Nessa to her friends. Is that true or no?
You said Nessa?
Oops. Can I call you Nessa?
No.
Okay, fair enough. Okay, you're co-host, so go ahead
Okay.
and present when you're ready.
All right, no problem. And then, okay, so I'm going to be doing my presentation on Parkinson's disease. So here's the table of contents. So this is what we're going to be discussing during this presentation. So first, what about the disease? Like, what is it? Pathology, symptoms, treatment, current research, and just in conclusion, just to like wrap up the presentation. Oh, it's not working. So about the disease. So Parkinson's disease, or PD, is a neurological disorder of the central nervous system that affects movement. It affects the dopaminergic neurons in the substantia nigra of the midbrain. So that means that the dopaminergic neurons begins to start showing signs of impairment or death, causing there to be less dopamine to be produced. And dopamine acts as a messenger between parts of the brain. So dopamine decreases the influence of indirect pathways and increases the influence of direct pathways within the basal ganglia. So direct pathways produces the desired movement and indirect does the opposite. And if there is a lack of dopamine, there will be a lack of movement, or the movement will be kind of like lagging or discoordinated. So here, as you can see, if you look to your bottom right, you'll see the midbrain, and then the part right here is the substantia nigra. So in a healthy person, it's like really dark, and then you can see here that the neurons are very like vivid and alive. And then in the Parkinson's disease, and a patient who has Parkinson's disease, you can see that the neuron looks very like dull, so that means that a lot of the neurons have died. So about 10 million people are affected worldwide, and men are 1.5 more likely to have Parkinson's disease than women. The incidence of disease, or the rate of newly diagnosed cases generally increases with age, although and can stabilize in people who are older than 80, and an estimated 4% of people with Parkinson's disease are diagnosed before the age of 50, and about 1 million Americans are thought to have Parkinson's disease, and people are more affected than people who have MS, muscle dystrophy, and ALS combined. And every year, there's 60,000 Americans who are diagnosed with Parkinson's, but that does not reflect the cases that have not been detected. So the pathology. So this is the science that causes the cause and effects of Parkinson's disease. So common causes of Parkinson's. So one of them would be genetics. So genetics are being passed down from the parents to the offspring. So researchers have identified that genes that have mutations could be related to Parkinson's disease. So these genes are the SNCA, which is in excess of the alpha synuclein, which is actually toxic to the brain. GBA1, which is a protein garbage management. So this system basically is a process of taking genes and disposing of them or unnecessary proteins when there's excess of them. And then there is the LRRK2, which is nerve loss. And for environmental, there's this can increase somebody's risk of developing Parkinson's. So toxins such as pesticides can be the main cause of environmental factor. And then the Lewy bodies, which is a biomarker of Parkinson's disease. So an excess amount of Lewy bodies that has a clump of the synuclein, the alpha synuclein in the brain stem cannot be broken down. And then other factors that can contribute to developing Parkinson's is medication. If somebody has another progressive brain disorder, cerebral vascular diseases. So if somebody has a stroke, age, or their lifestyle. So symptoms, so physical or mental features that indicates a condition of Parkinson's. So there's 5 different stages of Parkinson's. So stage 1, an individual experiences mild symptoms that generally do not interfere with their daily activities. Tremors and other movement symptoms occur on one side of the body only, and may also experience changes in posture, walking, and facial expressions. And then for stage 2, the symptoms will worsen, and including more tremors and other movement symptoms on both sides of the body now, and the person is able to live alone, but tasks are more difficult and they take longer. For stage 3, this is considered a mild stage for the individual, and they will experience loss of balance, slowness of movement, and while they're still independent, they're still fully independent, these symptoms significantly impair the activities such as dressing and eating, and they're more susceptible to falling. So for stage 4, symptoms are severe and limiting. The individual may stand without help, but movement will likely need a walker, and people with stage 4 generally need help with daily activities and unable to live alone. And then once they reach stage 5, they are wheelchair bound and bedridden unless assisted. And they're normally, at this point, they attend around the clock nursing care, and they may experience hallucination or delusions. So for some motor symptoms of the disease, there is bradykinesis, which is a mouse-like appearance, decreases in blinking and fine motor skills. This is also known as slow movement. So another symptom is tremors, which is a repetitive shaking of the body. And then there's which is a repetitive muscle movement and makes body parts twitches and twists, and then vocal symptoms such as speech change, so there will be a change of the speech or how they pronounce certain words. So for some non-motor symptoms of this disease, so there's mental behavioral issues, which includes depression, anxiety, fatigue, sleeping problems, and change in personality. Overall pain, so the person who has Parkinson's disease will just have pain all over, and they'll be like in constant pain. They'll have an excess of sweating and an increased chance of having melanoma, which is a pigment producing cell that gives color to the skin and becomes cancerous. And they'll have gastrointestinal issues such as urine issues, weight loss, and sexual concerns. So for some diagnosis, there's no specific tests that can diagnose Parkinson's disease. However, there are some tests that can help with diagnosing it, which is a DAT scan, which is shown an example at the bottom right where you'll see the scan. So in a normal person, you'll see like there is different colors that like indicating different aspects of like the brain. But then in the Parkinson's disease, you see like how it blends together and it kind of looks like more like a butterfly, like kind of like, or a bird, or it looks similar to what a bird would look like. And if it goes undetected, it may lead to deterioration of all the brain functions and can cause an early death. So for treatments, so there's not a specific cure for this disease, but there is medicines to help with the symptoms and help with like just making their life a little bit easier. So the main type of medicine is L-DOPA, which increases the dopamine level of the brain, and some drugs that accompany this, because if a patient takes this alone, then there's a lot of like risk factors and there's a lot of concerns when taking this medicine. So there's dopamine dopamine adjustant, I think, or mimic dopamine production. There is anticholinergic drugs, reduces tremors, and then MAOB inhibitors, which inhibits the breakdown of dopamine. And someone who also experiences PD can also have physical exercise, such as aerobic exercise, which can help with the movement and help like exercise the muscles that are often deemed like not useful. So current research. So there are some research that are in the process of being researched that will later on hopefully help cure PD, but these research are deemed unethical because it results in the destruction of human life for research purposes. So some of these research are stem cells, which create cells to turn them into dopamine producing neurons, NGF injections, which means like NGF means neuron growth factors, which some researchers think that there is a deficiency in PD patients, so they think if they inject them with these factors, these growth factors, that will improve their symptoms. And then the fetal cell transplant, which implanted to replace the dopamine production, so it's basically the same, like similar to stem cells. So in conclusion, so how do we cure this? So like the takeaway. So Parkinson's disease is a lifelong condition that involves neurological changes in the body. These changes can make it harder for a person to function in daily life. However, medicines and other types of therapy are available for treating Parkinson's disease and reduces the symptoms. Current treatments can relieve symptoms, but scientists hope that these gene therapy or stem cell therapy will one day be able to do more and restore functions that the person has already lost. And here's a quote from an actor who has Parkinson's disease. He says, "Our challenges does not define us, our actions do." Here is my reference, and that's it.
Okay, good. Let's open it up to the crowd for a little edification, edumacation. Mick Putney, are there any proposed reasons why men are more likely to have Parkinson's disease?
When I was doing my research, I didn't see any, but it did talk about how it's just like based on lifestyle, I guess, and also men like are more susceptible to having the gene that has Parkinson's disease. So that's all I saw when I was doing my research.
Okay. Could you summarize the treatments again?
So basically, there's L-DOPA, which is the main type of medicine that helps treat Parkinson's disease, but it cannot be taken by itself. So there's like different types of medicine that help like with the symptoms.
Okay. Any other questions, or shall we go on? Okay, I guess that's good. So we've got one more speaker today. And our last speaker is Tyler Montano. Okay, Tyler. So I'm not sure, Tyler, if you can share your PowerPoint. We're going to give that a try.
Yeah, sure.
Because we haven't seen your face all semester. We've missed your face. Or maybe I just forget what you look like. Maybe we miss it. I don't know.
So I'm like trying to share it, but it's not letting me share it. Okay, yeah, I can share it now.
Okay, yeah, I just set you up to share, so.
Okay, yeah. Is it sharing or no?
Yep, we can see that.
Okay, cool. So my paper is on the effects of psychedelic microdosing on mental health. Introduction. So psychedelics, as their name suggests, are psychoactive drugs that bind to the 5-hydroxytryptamine 2A receptors and activate them, causing psychological and physiological changes. The 5-hydroxytryptamine 2A receptors are found in multiple areas of the brain, such as the prefrontal cortex, the striatum, the ventral tegmental area, and the thalamus. There are many types of psychedelic drugs. However, the two most common types used for microdosing are lysergic acid diethylamide, LSD, and psilocybin, also known as magic or sacred mushrooms. There have been reports of psilocybin microdosing as early as the 16th century, where it was used as a form of medicine to treat fevers and rheumatism. Rheumatism is a pain in muscles and bones. So by the year 1943, psychedelic research increased greatly, and it was determined that LSD had mind-altering properties. This resulted in a massive increase in LSD consumption by scientists and was widely believed to have been the catalyst for the scientific and technological advancements of that time. These discoveries are supported by testimonies from great innovators such as Kary Mullis, who discovered how to automate the polymerase chain reaction, and Steve Jobs, who founded Apple. Both accredited their superior cognitive and innovative abilities to LSD consumption. So in recent times, psychedelics have been made use clinically to treat anxiety in terminal cancer patients and help reduce obsessive compulsive disorder in individuals. Psychedelic consumption has therapeutic effects that improve depression, lessens anxiety, improves somatic disorders and psychological conditions, and helps curb addiction to drugs such as cigarettes and prescription medicine. Full dose consumption often results in unwanted effects such as acute panic reactions, toxic psychosis, and extremely intense sensation that leads to users experiencing bad trips. Microdosing is consuming the drug at lower concentrations. It allows for all the positive effects of psychedelic drugs without the intense sensations or negative health reactions. Psychedelics have the potential to be very useful in the field of medicine due to its positive impacts on mental health and ability to cure long-term mental disorders. Additionally, it improves cognitive abilities, productivity levels, and enhances athletic performance. It also has the potential to be used as a deterrent for continued consumption of addictive drugs. Okay, so why microdose and not full dose? A 2018 study by John Starr reported that generally microdoses up to 1/10 of a total dose did not impede bodily functions and allow the user to perform everyday functions and activities. However, higher dose concentrations did not allow for complete bodily control to execute work and activities. Some users experienced microdose some experienced microdoses frequently consume LSD and psilocybin at various times throughout the week for many weeks, while others religiously microdose every day for several months. However, both groups of microdosers largely reported positive effects on their depression and anxiety, and various therapeutic effects with no feelings of intoxication. This indicated that the frequency of consumption did not seem to influence or prohibit the user's ability to attain the therapeutic effects of the drugs. These therapeutic effects provide relief from obsessive compulsive disorders, post-traumatic stress disorder, narcolepsy, and pain management of migraines. Additionally, the therapeutic effects of psychedelic consumption provided a useful alternative to help users quit cigarette smoking. Psychedelic microdosing was also reported to have positive impacts on energy, mood, and cognition, which helped in performing everyday activities. This increase in mood and performance allowed for more effective studying, completion of work tasks, raised open-mindedness, extroversion, and overall friendliness to relate well to others. Consuming psychedelics at full doses has most of the same benefits as when consumed at microdoses. However, full doses greatly intensify open-mindedness, self-awareness, and amplify feelings of enlightenment, and also promoted dissolution of the ego. Psychedelic concentrations at full doses have greater potency and efficacy at managing extreme chronic psychiatric conditions such as depression, anxiety, and post-traumatic stress disorder compared to lower concentrations of microdoses. The 5-hydroxytryptamine 2A receptor occupancy influences the intensity of the psychedelic effects experienced. Microdoses result in lower 5-hydroxytryptamine 2A receptor occupancy, thus producing milder psychedelic effects, while full doses bind more to the 5-hydroxytryptamine 2A drug receptor sites, thus producing the maximum effect of the psychedelic. These lower concentrations are more suited for managing milder stages of these mental disorders. Unfortunately, higher doses increase the risk of psychological trauma, physiological discomfort, anxiety, severe headaches, and chances of experiencing bad trips, with bad trips being described as one of the worst psychological experiences imaginable. All right, so before I go to the next slide, does anyone know the what is on this guy's fingerprint here? Well, this guy's thumb? Like what drug?
Vanessa says LSD.
Yeah, correct. Okay, so next we have effects of microdosing on mental health. A 2020 study by Lee et al. Reported that the average microdoser preferred microdosing with psilocybin for its efficacy in managing mental health issues. Majority of participants reported better moods, lower anxiety levels, greater ability to relate and connect to others, and improved cognitive and performance abilities, more than 50% of the time of psychedelic consumption. Furthermore, when used specifically to treat depression, anxiety, and other chronic mental disorders, psilocybin had a higher chance of improving conditions. Unfortunately, it was reported that psilocybin did not enhance cognition most times. Instead, LSD consumption was greatly associated with an increase in cognitive and performance abilities. LSD consumption at low dosages caused changes in the connectivity of the limbic system of the brain. There was an increase in connectivity between the amygdala and the frontal gyrus, which helped to improve anxiety. Additionally, microdosing functions as an alternative form of mental health therapy that not only reduces depression and anxiety, but also increases self-confidence and ability to tolerate others. For instance, low doses of psilocybin are used in psychotherapy for their potency due to being able to cause changes in consciousness and decrease anxiety for up to 6 months after one treatment session. According to Wheeler, 2020, psilocybin-assisted psychotherapy helps patients by allowing emotional catharsis, revised life priorities, self-awareness, positive feelings of self-love and happiness, sense of interconnection and acceptance of death, all of which positively impacts mental health. Additionally, just 2 sessions of psychedelic-assisted psychotherapy were enough to prolong antidepressant effects for up to 3 months in treatment-resistant depression patients. Although having positive effects on depression, psychedelics aren't considered antidepressants because of their 5-hydroxytryptamine 2A receptor agonistic activity, which increases sensitivity to the environment and emotional feelings. So, effect of microdosing on productivity. Psychedelic microdosing positively impacted productivity levels by enhancing abilities and overall performance by increasing creativity, conversion, and divergent thinking. For example, microdosers were able to overcome creative hurdles and writer's block due to a surplus of positive creative thoughts that allowed for openness on different perspectives on how to approach work, thus making it more doable and exciting. These psychedelic effects were especially significant in cognitively demanding and complex problem-solving areas such as software development, music composition, and academic work. Microdosing also positively impacted athletic performance and physical exercise by increasing energy, focus, coordination, and perception. Additionally, it provided an abundance of willpower and mental stability needed for extremely physically demanding sports such as MMA and long-distance running. It also encourages work-related opportunities that require efficient communication by enhancing extroversion, attentiveness, focus, and persuasiveness needed to influence others, while increasing sensitivity and ability to connect with and understand others, especially when receiving feedback, which allows for personal growth and improved leadership qualities in a professional or team-oriented environment. Anderson recorded 104 reports of increased positivity, 86 reports of improved energy levels, 61 reports of social benefits, and 120 reports of improved focus. A study by Johnson supported this data by reporting that the majority of respondents reported positive impacts on their energy levels and cognitive abilities, which allowed them to carry out everyday tasks and functions more efficiently. Challenges to microdosing. For various reasons, users may mistakenly consume more than the desired microdose amount, causing them to experience bad trips since psychedelics have powerful psychoactive effects, which sometimes render the user unable to perform everyday activities if taken above the recommended microdose guidelines. Another challenge is hesitancy and worry among... Wait, something just happened. Dr. Slish, I think something just happened to the slide.
Can you not change it or what? I can still see it okay.
Okay, well, all right, I just go with that. Yeah, okay. Yeah. So there's hesitancy and worry amongst users due to the lack of research investigating the full impacts of psychedelic microdosing on the body and the brain if consumed for extensive periods of time. Microdosing may cause uneasiness in full-dose users who previously experienced bad trips due to it having similar negative effects such as insomnia and overstimulation. The biggest issue of psychedelic consumption, whether it be microdosing or full dosing, is the fact that psychedelics are still vastly viewed as dangerous drugs whose consumption remains illegal in most places. There were 178 reports indicating hesitancy to partake in microdosing due to fear of consequences, lack of substance regulation, thus increased higher possibility of toxic impurities, the high cost of the drugs due to having to acquire it on the overpriced black market, and the uneasy feeling of having to hide while consuming or being in possession of psychedelics. Additionally, there were 109 reports of physiological discomfort, highlighting visual impairment, temperature dysregulation, reduced appetite, gastrointestinal discomfort, insomnia, and numbing sensations. Some users also reported cases of mood swings and over-emotionality, while others reported feelings of restlessness and jitters after microdosing. LSD consumption in particular was commonly reported to cause feelings of restlessness, fatigue, and physiological discomfort. This was also supported by Anderson, who reported that numerous research participants indicated that these feelings of overstimulation, insomnia, and increased impulsivity were primarily associated with LSD consumption over any other psychedelic. Most users reported this physiological discomfort and bodily overstimulation as unwanted effects that discouraged them from continuing microdosing. There were also reports of random gastrointestinal discomfort and increased body temperature at inappropriate times, feelings of restlessness, and disturbance. So, potential of psychedelic drugs. There may be potential for psychedelic microdosing being prescribed in medicine due to its effects on mental illnesses such as anxiety and long-standing depression. For example, Anderson reports that LSD microdosing was able to completely cure and significantly relieve depression in long-term depressed patients. Psychedelic microdosing also helps significantly relieve PTSD and bipolar disorder in mentally ill individuals more efficiently than other antidepressants. Routine microdosing effectively reduce dependence and addiction to addictive drugs such as alcohol, narcotics, various prescription drugs, and nicotine. Anderson supports this data by reporting that microdosing caused a 44.2% reduction in caffeine consumption, 42.3% in alcohol, 38.3% in cannabis, 21% in tobacco, 17% in psychiatric prescription medicine, and 16% in other illicit substances consumed. There were also notable improvements in cognitive and social abilities in microdoses with neuropsychiatric conditions such as ADHD, attention deficient hyperactive disorder, and ASD, autism spectrum disorder, with some microdoses reporting added relief from extreme stuttering. There are numerous reported benefits of psychedelic microdosing on the brain. One odd benefit in particular is its ability to reduce the pain intensity of headaches as well as their occurrence. Additionally, there was another strange report adding to the benefits of microdosing. It was reported that microdosing psilocybin mushrooms had the potential to improve neurological disorders. For instance, one paralyzed patient reported regaining control of bladder function and regaining some sensations in the lumbar region. So, in conclusion, psychedelics are effective psychoactive drugs that have positive impacts on human health, such as improving mental illnesses and disorders, increasing cognitive abilities, and enhancing both productivity levels and athletic performance. Although there are some unwanted risks associated with consuming psychedelics at full doses, these risks are completely alleviated through microdosing. Microdosing provides the same benefits as full doses, but without any terrible risks. It also may be potentially utilized as a form of medicine in the future to cure long-term mental illnesses, or it may be used as an effective method to curb addiction to addictive drugs. And these are my references. So do you have any questions?
I've got a quick question. Is that a rooster I see back?
Is that a, oh yeah, they have a lot of animals around me like right now. So it's probably a rooster, yeah.
Oh, that's so cool. Visit you sometime. That sounds awesome.
Okay.
Okay, a different question from Nick Putney. Are there any known negative effects of long-term psychedelic use?
Are there any known negative effects of long-term? Oh, well, they have some negative effects of like short-term use. Like some users reported experiencing negative effects, right? Like it's not the same for everyone, but they do. Well, I didn't get any long-term effects because there isn't much research done on the psychedelics, largely due to it being like still illegal in most places. So not much research is being done on it.
Okay.
Any other questions?
Any other questions? Question points. All right. Well, what do you say we wrap it up there, folks? And if you
there was another question.
Was there a question?
In the chat, there's.
Oh, hang on. Oh, is there specific parts of the brain it affects?
Yeah, well, it has specific parts that it mainly acts. So what I said in the first slide is that it binds to the 5-hydroxytryptamine 2A receptors, right? And these are located in multiple areas of the brain, such as the prefrontal cortex, the striatum, the ventral tegmental area, and the thalamus. So, yeah.
The thalamus.
Yeah.
So the VTA is involved in dopamine release and reward, I believe. And, but never mind.
Okay.
Okay, any other questions? Okay, well, if you gave a talk to, oh, wait, hang on. Michelle Simmons, did you look at the effects of hallucinogen persisting perception disorder, HPPD? And if so, how common is it for those who take psychedelic drugs? So that's, flashbacks, basically, hallucinogenic flashbacks.
Oh, I didn't really look into it I didn't look into that at all. However, some users reported like they sort of had flashbacks, but they had more like feelings of nostalgia that, okay, so some users, they took full doses and they experienced bad trips, right? So they were a bit hesitant to microdose again because they found out when doing it, it gave them feelings of like nostalgia, like they sort of had a flashback of the bad trip microdosing. So that sort of like prevented them from partaking again. I'm not really sure if that like answers your question, but that was like all I know on it.
Okay, here's a question from me. Do people who microdose get hallucinations or not?
Some people say yeah, and then some people said it's more like a therapeutic effect, like you just feel nice. But some people say yeah, they hallucinate. Yeah.
Okay. All right then. I'm going to call it a day here. And again, if you presented today, I'll send you an email in a moment. We'll talk about your talk. And if not, then we will see you on Thursday.
Hi, I just have a quick question though about the resume and cover letter.
Oh, okay, resume cover.
So for the cover letter, you mentioned that like it's supposed to be tailored to specific, whatever you're applying to.
Right.
But like, what are we applying to?
That's up to you.
Okay.
It's kind of an academic exercise in that you're not actually applying, but find something you would like to apply to, even if it's a grad school, same thing.
Okay, thank you.
Any other questions, comments? All right, well, let's call it a day. See you Thursday, people.